Welcome to the One Piece Implant Mentor podcast. I am Dr. Andrea Joy Smith, your host and your mentor. The One Piece Implant Mentor podcast introduces our audience to scientists, pioneers, and doctors leading the way in the world of one-piece dental implantology. My guest today is one such pioneer. Dr. Dennis Flanagan is in private practice in Mystic, Connecticut. His contribution to dentistry extends far beyond one-piece dental implants. He is a researcher and has published in several dental professional publications. Dr. Flanagan, welcome to the podcast.
Thank you, Andrea.
Dr. Flanagan, can you tell us a little bit first about your private practice in Connecticut? I want to hear a little bit about your dental journey in general.
Well, I'm a former managing partner and president of Connecticut Dental Groups. We had a large private practice that had 35 employees and 17,000 patients, and that's a great knowledge base for gleaning information and research from. So consequently, I was able to use those patient experiences to write articles. I get out of work between 5 and 6 o'clock at night. My wife gets out around between 7 and 10, so I've got a couple of hours there every night to work on things, and so that was my modus operandi. I would come home and write a couple of paragraphs every night, and then pretty soon at the end of a couple of weeks, I've got an article written. It's kind of fun, I get an idea at work, and a paragraph comes to my mind, and I write that. It's a fun way of living a professional life. I enjoy doing that.
That is great. Well, with such a large patient base, 17,000 people, I'm sure you've seen just about everything from conventional implants to one-piece implants. And I'm sure you have a lot to share with us on that front. I want to talk to you a little bit about what actually attracted you to the one-piece dental implant or the mini dental implant.
I started placing implants in 1989 after the NIH conference. I took my first implant course in 1971, so I've been at it a long time. But I noticed that some sites you can't adequately place a standard size implants in.
Correct.
So consequently, I did look into mini implants when Victor Sendex was alive. I found that they are the perfect fit for a lot of clinical situations that standard size implants or two-piece implants are inappropriate for. And what happens is when you put a standard size implant or a two-piece implant into a site that's too narrow, too thin, widthwise or lengthwise, you compromise the blood supply, you compromise the thickness of the surrounding bone. And we all know through Spray's work that it's very likely that we need 1.8 millimeters of bone around an implant for appropriate long-term functional aesthetic outcome. So when you have a larger size implant like that, two-piece, for example, the bone becomes thin and remodeling then is compromised. The osteoclasts work, but then the osteoblasts don't seem to work very well. Consequently, you get bone loss and gingival recession. So it's a natural phenomenon, the physiology, that happens. Mini implants with one piece fit the bill for a lot of different situations. Not every situation, but for a lot of situations.
Yeah, I agree, because oftentimes when patients are missing their teeth, the alveolar bone, of course, goes along with it. And so by the time it's time to restore it, they may or may not have that 5 to 7 millimeters of bone or whatever amount of bone that you need to place a larger diameter implant. So having a smaller diameter implant option makes perfect sense.
There's also the issue of the micro gap between the abutment and the implant fixture. The body has been shown to be a culprit in colonizing various species of bacteria in that vacant space. And of course, you all know nature abhors a vacuum, so consequently, that empty space will be filled by something. It's usually bacteria.
Absolutely. And so that's one of the benefits of having just one piece where you don't have the micro gap and the constant motion sort of percolating the bacteria down the axial surface of that implant. So that's a really good point as well.
It's interesting you say percolating because that's exactly what happens, because when an implant's under load, a microscopic rotation or luxation of abutment occurs against the fixture, and there's an inflow and outflow of products from whatever is growing or colonizing the inside of the abutment, and consequently that's called percolation in a form.
Yes, absolutely. As I mentioned before, you are a well-published author in a lot of dental professional publications. And so I want to talk to you a little bit about some of the findings and some of the studies that you have done in order to author those studies. I was reading an article that you published in 2015 in the Journal of Oral Implantology. You talked about using mini dental implants to support posterior fixed bridges on a select group of patients that have the conditions that will allow it. Can you share with our listeners some of the conclusions that you drew from that study?
Controlling the load of the implant is so key. The reason for that is because a mini implant applies at least twice the load on the surrounding bone, the embedding bone, the supporting bone, as standard size implants. So what that means to us, we have to control the load. That means we have to control the occlusal forces on those implants and the prosthetics that are supported by them. So consequently, the bone needs to be dense, and the prosthetics needs to have a narrow occlusal table, rounded edges, and made with a material that's not going to require a lot of maintenance. I've got plenty of cases out there that I placed in posterior areas of the mandible especially. They're still in there now. It's been like 10 years. Narrow occlusal table and controlling the occlusal loading. No off-axial loading. That has to be totally avoided.
I also saw that in 2016 you published a study that talked about splinting implants together to distribute the forces. Can you talk a little bit about that as well?
Yes, when you're dealing with mini implants especially, splinting the joining implants is very important because it distributes a load that you're applying to the prosthetics and subsequently to the implants and subsequently to the supporting bone. So consequently, since the load is higher on the bone than it is for standard size implants, we want to distribute that load over the maximum number of implants we can. That means we have to use more implants that we'd normally use for standard size implants. Where you put one standard size implant in, you probably have to put in 2 or 3 mini implants. So consequently, the load is distributed under that supporting bone in a much greater fashion.
That's a great concept, and I often do that as well. Can you explain why the small diameter implant exerts 2 times the force on the bone as a conventional implant?
Sure. If you're just thinking empirically, taking the area of a 2 by 10 implant, let's say, that's 20 millimeters of area. And the standard size implant, let's say 4 by 10, that's a 40 square millimeter of area. And you put a 200 Newton force on that. The standard size implant is going to exert 5 Newtons per square millimeter, but the mini implant is going to apply 10 Newtons per square millimeter. And this has been backed up by subsequent research that shows that mini implants apply between 1.5 and 2.5 square millimeters of force on implants compared to standard size implants. So empirically it works out, and also in actual research it works out.
So that accounts for not having any off-axial loading and also being able to distribute the forces so that it can take all of that load. Is that correct?
Yes, most of the load is borne by the cortical bone, of course. But if you have a small area there, that's going to be much more of a load on that bone than would be standard size implants. So we've got to control the off-axial loading. Implants will take a tremendous amount of load axially, but when it comes to off-axial loading, we've got to be careful about that and control our occlusal forces.
We talked about fixed, but what about the removable appliance? Why is it that we can immediately load the removable appliance when we stabilize a denture, for instance, or a partial? We want to reach, of course, a certain amount of torque, but what is it about the one-piece implant that allows that immediate loading, reaching that 30 Newton centimeters torque?
Well, you can immediately load standard size implants also, but they have published an article about that years ago on immediately loading implants, but that depends on the patient's bite force capacity. So most patients have a bite force of, let's say, around 200 newtons, but some people out there have a bite force capacity of 300 newtons. So immediately loading them is a little different story. Luckily, they're not a high percentage of our patient population, but they're out there. Consequently, that might be explains why 10, 20 patients that you've been successful at, and all of a sudden you get a failure. Also, it's very important that those implants replace the dense bone. You can't be putting these implants with standard size or mini implants and type 4 bone and immediately load and expect to be successful. It's not going to work. You can do bone densifying, but the jury's still out on that. I'm not sure what the result of that might be, but it's certainly a consequence of loading versus the density of supporting bone.
Well, what about the concept of getting bicortical stabilization in that posterior maxilla with the inferior wall of the sinus floor?
That certainly works. Support like that works out very nicely.
Speaking of anatomical structures like the maxillary sinus, I've listened to a lot of your lectures on the anatomy that we have to consider, the vital anatomical structures that we must avoid. Can you talk a little bit about some of the lesser known or lesser thought of vital structures that we have to consider? I've heard you talk a lot about that incisive nerve complex and the mandible. And we're always thinking about the inferior alveolar nerve, the mandibular concavity, but oftentimes right in the front here, there's that plexus of vasculature that we have to worry about. Talk to me a little bit about that and what happens if we don't respect that.
Most people consider the anterior mandible a safe place to put implants. And that's true for the most part, but some patients have a single sublingual artery that enters the symphysis of the mandible from the lingual side. And if you cut into that, you can create a significant bleed. Now, usually that's in the direct midline of the mandible, but sometimes there can be 2 arteries there that are of substantial size, that are off center of the midline. If you place your implants without a cone beam, which you might not consider doing that because that's a safe location, in quotes,
Right.
you can cut the artery intraosseously. In other words,
Okay.
with no perforation of the cortical bones with your drill, but because the artery is located intraosseously, the cut artery then retracts into the floor of the mouth and then creates a huge hematoma. Now, this is not life-threatening unless the hematoma pushes the tongue to the back of the throat, and then it can be life. And in that situation, you immediately want to put an airway in and call 911. I published an article
Absolutely.
with 3 oral surgeons from Spain about this, and they had 3 patients like this. They hospitalized 2 of the 3, but the third one was not hospitalized because he came back 2 days later with this hematoma. He was not in distress, so they let him go home. The Andrea Med was not a totally safe place to place implants. You got to know what your anatomy is and what structures there are present there.
That's a good point, because when I first learned to do one piece or mini dental implants in 2007, we were taught that it is a very safe place. And of course, we're always concerned about the mandibular concavity, the inferior alveolar nerve, the maxillary sinuses, the nasal cavity. But that lower incisive plexus of vasculature is something I wanted to touch on, because I've heard you speak about it before. And it's something that I really hadn't thought about, because I was always just sure that I was in a safe place. Now, fortunately, I never went dead center. I'd always go to the left or to the right of it. That is something I wanted to bring up with you, because I know that you've talked about it before, and it's something that I've listened to. And so every single time that I place implants, when I'm looking at the CT, I'm looking for any indication that there's some vasculature there. And sometimes we wouldn't expect an intra-bony vessel to create such a big bleed, because it's inside the bone and we're cutting through the vasculature of the bone all the time. But because that artery has a large area to supply, I guess it does make sense that that one we have to be extremely cautious about.
What can happen, the artery, when it's cut, retracts into the floor of the mouth. Nonetheless, cut to that artery and it does not retract into the floor of the mouth, and you place your implant, then the artery is then closed off and won't be bleeding. There's enough vasculature there won't be any necrosis of the bone or anything like that. Well, probably not. The arteries that come in through there from the submental and the sublingual, and there's a lot of anastomosing with the inside mental artery, so consequently, if it does retract to the floor of the mouth, you can get a relatively large hematoma.
How often would you say that happens, that it actually retracts in the floor of the mouth rather than just being slightly violated or entered and then being able to cut off the flow of blood with the implant? Is that a 50-50 chance, or is it more likely than not?
I think the chance is pretty low, but people have these misadventures, and they probably happen more frequently than we would imagine. There's actually no data about that at all.
You also talk about just the physiologic advantages of one-piece implants, the fact that there's less percutaneous exposure. Can we talk a little bit about that?
When you take the circumference of a mini implant, it's about 3 or 4 times less that of a standard size implant, depending on the modality. That creates less of an exposure for oral bacteria. So, larger standard size implant, the linear exposure of the circumference presents itself to the bacterial that's in our mouths at all times. And if there's a minor break in the epithelial attachment there, it creates an exposure. But with a mini implant, the risk of that is very, very low. In fact, once the mini implant successfully integrates, I personally have never seen periimplantitis or perimucositis in mini implants. The percutaneous exposure is so low.
That's quite different than the periimplantitis that we hear about in conventional implantology.
Yes, well, there's some work out there that demonstrates that the larger the implant, the more susceptible it is to periimplantitis.
Wow. And what about the fact that because the implant is smaller, there is more osseous blood supply available? Does that have credence as well?
Yeah, I think so. Obviously, we have to worry about the load because the displacement is so low, so small, that it doesn't inhibit bone remodeling. I think that's so key. As Reina's work pointed out, we need 1.8 millimeters. That's generally accepted. It's not the law of the land. Thickness of bone, but that thickness of bone contains about 50 osteocytes in that length. All those bone cells need to be supplied with vasculature, and because that bone provides that. The medulla provides that vasculature, so we can get appropriate remodeling, osteoclastic and osteoblastic activity, which goes on all the time, and we need to have that to support the implants.
And another physiologic advantage you talk about is the fact that the silhouette of the implant is much smaller presents less of a barrier to angiogenesis. Is that correct as well?
Yeah, I think that's the case. The sequence for bone is inflammation, angiogenesis, then osteogenesis. The bone cells need to have a blood supply, before they can even enter the area. So consequently, the less displacement we have, there's less of a physical impedance or blockage to the formation of blood vessels and subsequent bone growth.
Let's say you place an implant in an immediate extraction site, for instance, on the lower anterior, and you have plenty of basal bone to engage the implant. Let's just say 60% into the basal bone that's surrounding. And there's a few threads that are in the space of the extraction site. If the facial wall is still intact, do you typically graft that area, or can we depend on bone to grow right up to that implant? And what keeps the soft tissue away if we can't?
This is a very complex question here, but basically, if we're limiting this discussion to the anterior mandible, then we have to use a very long implant. And we want to engage that anterior mandibular bone for stability. We want to have that mini implant very rock hard solid. Now we can measure that with this new device. Penguin now has a device to measure stability with displaced implants. If we have the appropriate criteria, we can immediately load those. But still in that gap in there, the thinking is if there's 2 millimeters or less, you don't need grafting. I probably graft those sites anyway, just because to maintain the space, to make sure if you have dehiscence that you don't detect or fenestrations, that's filled in just to maintain space for the new bone growth. And then, of course, you want to close off the area just to prevent ingrowth of bacterial substances in the saliva and food debris and things like that. And then I would probably put a little barrier in there. The article I published used dermal allograft, which is okay, but you got to be careful with that stuff because it can be colonized by oral bacteria. The little edges can't be exposed to the oral bacteria because it'll be colonized. It's got a not very pleasant odor when it is colonized. But it's certainly very possible. But again, stability in the bone is very important.
And the growth of that crestal bone that's going to fill in that space between the socket and the top of the implant where the implant threads are at their most superior level. Is that crestal bone going to grow back as strong as, let's say, the crestal bone adjacent to?
I would think so. You have to place the platform of the mini implant below the rest of the bone of the lingual plate. Sometimes the facial plate is gone, but it's got to be at least 2 millimeters below that to make sure you get good bone growth. You're going to get some bone loss from that crest of that lingual plate, but 2 millimeters below should be enough. And of course, you fill your socket up with graft material. What I would like to use is allograft and a little bit of calcium sulfate in it to make sure it's really opaque. That way it shows up on your x-ray better. And then, of course, barrier on and then close up so there's no food debris and bacteria as much as you can. Bacteria get everywhere, and they're going to get in there, but you want to minimize their activity so they don't colonize your graft material. And, of course, calcium sulfate helps prevent that, too.
Wow, those are all great physiological and anatomical things that we should definitely think of. I'm going to go back to your practice, the large practice that you were a part of. Did you have a large population of patients where you did one-piece or mini dental implants?
Yes, to me, the most effective and satisfying way of mini implants is you have a patient that comes in with a very atrophic mandible and the lower dentures just floats around and they're having very difficulty eating. They take 2 bites and they swallow food whole. They're older people usually. There's one patient who was 94 years old and she was miserable. She just wanted to have a good quality of life. So I put in the 4 mini implants in the lower jaw, immediately loaded them. She walked out the door and came back a couple days later. She was ecstatic. She could go back to eating food again. She was very happy that she could eat things and enjoy her life, go out with her friends and family, and order from the menu without having from the child's menu, or pureed menu.
Those are the patients that will give you the biggest hug and express the largest amount of gratitude. Often we do a lot of hard work on a patient, like a root canal on tooth number 15 or something like that, and we're very gratified because we've sealed it all the way to the apex and we've got a little bit of cement that express, but that's unbeknownst to the patient. They're not the ones with the most gratitude. So I'm sure you experienced that as well.
Yeah, on a personal level, I think it's very important that we as professional dentists and healthcare practitioners, that when you do a good job, something comes out really perfectly. I just keep that to myself. I know what I did. I got the feeling of, yes, got it, nailed it, that kind of thing. Enjoy that feeling. That's bragging at my family. I have a son-in-law who's a dentist, and I brag every once in a while, but that inner feeling of warmth is a reward enough for me.